what would be a standard of best practice, or what we would want to aspire to, is being able to give the time, first and foremost, to that space and to that patient to really understand what it is about that look that they desire to be, what that's going to achieve for them, and not in physical terms. But again, it's having that person to be able to, who's skilled enough to be able to sit with that person. So if the practitioner doesn't feel like that's their area of expertise, then being able to refer safely within their team to be able to have that conversation. Because what we don't want to start to do is create barriers where this patient feels like they're not being listened to, they don't know what's going on, they're being misunderstood, they just want to look like this picture, everybody's doing it right, you know. So it's really important that this is streamlined and it's smooth and it's integrated from that step one ultimately. And we can take it further back from just that moment in which you present that picture, because before that you would have filled out an inquiry form. So the practitioners can start to look at, well, what was on that inquiry form? Are we gathering enough information so that we can safeguard this person? Is there a safeguarding concern? You know, is the ambition to let this person because there is somebody telling them that, you know, that they're not good enough the way that they look, and they need to look like this person in order to be worthy. So there's lots of things that we can explore. But at that moment in time, ultimately, we want that patient to feel safe, supported, and heard and understood, and to be going away with a more critical ability to think through their decision. And what we absolutely don't want to be doing is assuming that because a patient is seeking a treatment, they want to go ahead with a treatment. So we need to be providing that space. Again, it's that time, it's that cooling off period, a minimum of 48 hours, so that they can think about that treatment. It also gives the practitioner time to get their ducks in the row. If it doesn't feel comfortable, what can you do more for that patient? If that patient was your friend, your sister, whomever, how would you want them to be treated? And it allows you to just engage on that more human level, just to slow things down. It's really important to make that pause. And if that patient is not suitable for treatment, they need to be aware of that at the point of stepping in the clinic, where being really transparent is so important, so that when that patient, you know, delivered the bad news, actually that bad news could be the most rescuing news that patient has heard, because actually they may not really want that treatment for themselves. It might be on the back of those influences elsewhere. The really important thing is time. As I say, looking at those information gathering points, those touch points of how and when you can start thinking, talking, looking at that bigger picture. And for me, they should be there at the very, very beginning. And if that patient is leaving feeling underwhelmed, you know, feeling like, well, they wanted that treatment today, there and then. Again, all of this is giving you information that says it's not the right service for that patient. And I think we have to really feel confident in being able to say no to our patients. No doesn't mean no and never. It just means this treatment for you right now isn't going to give you the best outcome. And we need to be skilled and clued with the language that we use to our patients, because simply saying, no, I'm not the right practitioner for you, can sometimes just fuel the energy for that to go on to another practitioner. And this is where we can perpetuate just more harms as a sector. So we really need to be able to slow that down for ourselves, the practitioner as the patient, tap into those resources, make those referrals, and allow that decision to be made in a really informed, slow, thought through way.